Hello and namaste. This is Dr. Srinidhi Chidambaram hosting the COVID Care series presented by Apollo Hospitals. I hope you're all staying safe and staying healthy, and I do hope that you have remembered to have all your spaces well ventilated as per the latest guideline. Open those windows as much as you can. COVID 19 is now on all our minds one way or another. Someone in our family or someone we know could be affected. And for those who don't have COVID 19, the thought of getting the infection is quite frightening. Once a person has COVID 19, any admission into the hospital itself is worrying for the family. But ICU admission brings out tremendous anxiety, and one imagines the worst. But please don't worry, because first of all, everybody who has COVID 19 infection doesn't even need hospitalization. And even those who go into hospital and even into critical care to the ICU, many of them have done tremendously well, and they have successfully gotten cured and come out safe and healthy. And our intensivists are certainly working 24 by 7 to get the COVID 19 patient better. And it is important to understand what care is given inside an ICU for a COVID 19 patient when they need that kind of a critical care, and how lives are saved every single day. So, to demystify the critical care for COVID 19 and to understand the many measures that are taken in ICUs, I'm very happy to welcome Dr. G.J. Himaldev, MBBS, MD, FNB Critical Care and EDIC Dublin. He's an intensive care specialist at Apollo Hospital, Seshadripuram, Bangalore. Dr. Himaldev is trained in medical and cardiac intensive care management. He has over 8 years of experience in managing intensive care patients. He has also worked in intensive care units at the Royal Adelaide Hospital, Australia. He specializes in ECMO management, airway management, mechanical ventilation, advanced cardiac life support, trauma management. He has also received a gold medal for his performance in the MD examination and was the best outgoing PG student from the Kasturba Medical College, Mangalore, Manipal University, and has several publications to his credit. Hello, Doctor, and I'm so happy that you're able to join us today at our COVID Care series. And I do hope that you will be able to give us a very illuminating overview on what is the role of critical care management in a COVID-19 patient, when would they need it, what are the modalities of management, and what are the possible outcomes, and how patients and their families need to not have misconceptions about critical care and how successful outcomes are happening every single day.
Thank you, Dr. Srinidhi, for that introduction. And good afternoon, everybody. I think this is the right approach to demystify what happens in the critical care unit, because many of us are not aware what happens inside the ICU. As you know, intensive care unit means itself that patient requires a special care, and the patient has to be critically ill before we admit somebody.
Doctor, can you speak a little louder, because you're not very audible there?
Can you hear me better?
Yes, Doctor.
Okay.
Please go.
Sorry for the interruption. So as I said, in an ICU, there will be a lot of critically ill patients. So COVID also has been divided into mild, moderate, and severe. And mild is usually the people who have prodromal symptoms, and the moderate ones are the ones who develop some kind of breathing difficulty and require a hospital admission. And the rest of the people who become more in respiratory distress, they are the ones who require intensive care, etc. So if you divide it, around 85% of the population, they are the ones who have the prodromal stage. 15% of the patients, they are the moderate illness patients who require a hospital admission. And rest 5 to 8% of the population are the ones who are critically ill, who requires intensive care unit setup. And when we speak about the management of an intensive care patient, so how do we get these patients? What sort of patients we have in our intensive care setup? So basically, we get patients. COVID usually affects the lungs, and whenever there is a lung involvement, there will be a respiratory distress. Their oxygen requirement goes up. So we get the patients who have breathing difficulty. That's the most common presentation. Other than that, patient can also have some other complications because of COVID. They also present in a prothrombotic stroke state, which is also which can present like a myocardial infarction, pulmonary heart attack. They can also present like a stroke. It's called cerebrovascular accident. Sometimes some patients, when it is delayed, they can also present in a cytokine storm, where they have severe hypotension. That means the blood pressure is low. These sort of patients, they require an intensive care setup. And how do we manage these patients? Basically, these patients will have a high requirement of oxygen. So when do they come to the ICU? We try to supplement with them with some machines called as a high flow machine or a non-invasive ventilation setup. So these machines provide high concentration of oxygen to the patient, which helps to meet the demand. Along with that, it also helps to support the respiratory efforts. So high flow is nothing but a nasal cannula which goes into the nasal tube, provides a very high flow of oxygen and also very high concentration of oxygen, and helps to meet the patient's demand. When some patients doesn't get better, their oxygenation doesn't get better with these kind of machines, we provide them with something called as a non-invasive ventilation. So here we provide them with a mask that also supports the respiratory efforts of the patient and also provides oxygen. When all these supports doesn't help the patient, in case they become more breathless, their respiratory distress becomes more, we have to put them on something called as an invasive ventilation, also called as a mechanical ventilation. Here, we have to pass the tube into the trachea and adequately ventilate the lungs, support the lungs, which are already infected because of COVID, and help the oxygenation to happen and also to remove the carbon dioxide, which is also an essential part, thus maintain the ventilation part. So that's how the respiratory support happens in case of COVID ARDS. This COVID pneumonia is also called as the respiratory distress syndrome, also called as ARDS. Then even in spite of mechanical ventilation, patients' lungs can still get worsened, and they may not get better. The oxygen level still can go down. So in that scenario, what we do is we use something called as a prone ventilation, where we make the patient lie on their chest, and this helps to there are certain part of the lungs which are not ventilated, especially the dorsal part of the lungs. When we make them prone, this part of the lungs also gets ventilated, they get recruited, and there are chances that the oxygenation can get better and the patients can get better. So this is one sort of ventilation which requires highly skilled professionals and also a lot of manpower and also proper critical care management. When all of these measures fail, there is something called as a life salvaging measure, or as a last resort, we put some patients on something called as an extracorporeal membrane oxygenation. So this is nothing but an artificial bypass machine. It's a lung, or you can always call it an artificial lung bypass machine, wherein you take the blood of the patient, you pass it through the machine where it has an oxygenator. The blood gets oxygenated outside the machine and it is given back to the patient. It is a complicated process. It has its own complications, and it is not a particular treatment for the illness. It just helps to buy some time so the lungs can recover when the lungs are infected and they are on ventilator, and none of the measures are helping them. So this is how the mechanical supportive measures helps in case of COVID patients. Coming to the medical part of the treatment, as we know, there are few things which have been approved and which have been studied well. One of them is steroids. So when the patient becomes hypoxic, that means the saturation level goes below 92%, and they are in respiratory distress. When they need the ICU care, we usually start them on steroid dose, which is an anti-inflammatory. The dose usually we give dexamethasone as a steroid, 6 mg OD. As an alternative, we can also use methylprednisolone. There have been a lot of discussion going on about the dosage of steroid, how long we have to give the steroid, and which steroid is better. The evidence so far is mainly based on the dexamethasone, and as alternative to dexamethasone, we use methylprednisolone. There is no strict convincing data to say a higher dose of steroid is going to be helpful, or a longer duration of steroids is going to be helpful. We usually restrict the dosage of steroids for 10 days. Then the next one, which has been quite talked about, is the anticoagulation part. This because this COVID is a prothrombotic state, and there are a lot of microvascular antipathy which happens. So to counteract this, we need to start them on anticoagulation. We usually use low molecular heparin, that is Flexane, or sometimes we also use heparin, 1 mg per kg body weight, subcutaneously BD dose. Other than this, there is something called as remdesivir as well, which is an antiviral drug. And this also doesn't have a strong evidence in terms of mortality, but definitely there has been some evidences saying that the oxygen requirement and the recovery also is better whenever the remdesivir is given early, within the first 10 days of the illness. That is the viral phase of the illness, but not too late. And usually we give remdesivir 200 mg on the first day, and we give 100 mg daily for next 5 days. We need to be very careful with these drugs because it has there are chances of anaphylactic reactions, and in case of kidney impairment and hepatic impairment patients, we need to be cautious with the dosage as well. Other than these medications, we also give antibiotics, especially when the patient has a secondary bacterial infection. Usually when the patient goes on ventilator, there are chances of developing the ventilator-associated pneumonia, and we need to cover that as well. Some patients will have central lines to give medications. Some patients will have arterial lines to monitor the vitals for the pressure monitoring. These sort of patients also tend to develop certain secondary infections, and we need to counteract that as well. And this is the medications part. Sometimes COVID also present as a cytokine storm. This is the later phase wherein the host inflammatory response is more. The more inflammatory cytokines cause more damage to the body. To suppress these, there are few drugs called as monoclonal antibody drugs, like tocilizumab, which is the one which has been studied in the recovery trial, which is given within 24 to 48 hours of rapid deterioration in any patient, hypoxic patient. Then there are chances that, and when the patient has a high inflammatory cytokines, there are chances that they might be useful as well. But it itself has a lot of side effects, that these drugs will cause further suppression of immunity, and also it can lead to rise of secondary infections later on in the body. So this is about the medical aspect of the treatment of critical infection. Now coming to the most important part, the people are afraid that anybody goes on ventilator, that is the last death sentence. It is not at all like that. A lot of patients have recovered even after going on a ventilator. Initially, there was a controversy that we need to delay the ventilator phase because the chance of mortality is high. But nowadays, as the evidence evolves, as the experience improves, we are not waiting longer time for the patient to go on ventilator. If the patient is in respiratory distress, his oxygen requirement is quite a bit high, and he cannot tolerate with smaller machines. We have to put him on a ventilator, give him something called as a lung protective ventilation, just like non-COVID pneumonias, what we used to practice before. And we need to maintain them in such a way that they get better with the ventilators. Other than this part, there is usually a recovery of on ventilator around, there's a large gap between 30 to 80% of patients they recover, but depends upon which sort of patients. Like some patients it may be an early, for some patients it may be a later. So we cannot decide exactly. You have to decide based on the clinical parameters of the patient. And other than this, the routine ICU measures are also very important. The patients needs to have a strict blood sugar control, because the patients will be on steroids, and there are chances of fungal infections. As we know, mucormycosis is very evident nowadays. Other than this, the patient has to have a good nutrition. Patients have to be having any other pressure sore complications has to be prevented by using adequate care. And the fluid management is also a very important aspect in case of critical care, because they say the evidence also suggests that the negative fluid volumes are a euvolemia, which is going to help in the recovery of the patient. The more the positive fluid balance in the patient, the recovery is going to be delayed and the mortality is also going to be high. So these are all the important aspects of the critical care management of COVID-19 patients. As I said, there are 5 to 8% of critically ill patients in the COVID-19 patients, and if you give them treatment early and in a right way, there are definitely a lot of patients who get better even from the intensive care setup, and they do well in the future as well.
Doctor, I wanted to ask you, for a COVID patient, are there any particular tests that indicate that this person must go into the ICU?
That's a
What are the
fantastic question.
diagnostic markers?
Yes. So as I said, clinically, when you monitor the patient, that is an important aspect. But sometimes these tests can also guide them when to go into the ICU. So there are some inflammatory markers, which are nothing but the C-reactive protein, interleukin 6, and ferritin levels. If they are on the higher trend, then there is an indication that the patient may require uh, a ventilator ICU and a ventilator support. Other than these, sometimes the imaging also can guide us. May not be exactly the severity of the CT scan may not exactly correlate with the clinical illness, but there are rough guidance that if the serious severity is more, this patient may likely go to the ICU. And also, of course, the monitoring levels like SpO2 monitoring levels and his respiratory efforts, all these things also guide us when the patient requires an ICU. Other than this, one more thing we need to be more cautious is certain subset of patients, like patients who are elderly, patients who are immunocompromised, like patients who have malignancy or they are on some sort of steroid therapy or immunosuppressants, patients who have chronic kidney disease, patients who have comorbidities like diabetes, hypertension, ischemic heart disease. All these subset of patients, they tend to become more severe, and they are the ones who should be looked out for the requirement of ICU.
Also, in the ICU, not everybody goes into ventilation. So, could you explain, like, what is NIV?
Yes.
What are the different airway support that we give to our patients?
So when a patient has a respiratory distress because of pneumonia and the oxygen level also goes down, not everybody needs to go on ventilator. So we have something called as a high flow machine, where you put two small cannulas in the nose and you provide a very high concentration of oxygen. And the patient can talk with this, patient can eat with this, and patient can interact with the family as well as the doctors and nurses inside the ICU with this. They will just get a small pipe in the nose and they get the oxygen, and it helps to bring up the oxygen levels. Some patients will not be able to tolerate that high flow. So in those sort of patients, we provide something called as a non-invasive ventilation. It is not an invasive ventilator. We use a mask. It's a bigger, a tighter mask, which provides a higher pressure of air as well as higher oxygen concentration and helps them to breathe. Here also, the patients will be conscious. The patients, when you remove the mask, the patients will be able to take their food. They can talk to the family as well as the medical staff there. When these sort of most of the almost 50 to 60% of the patients, they tend to get better on these, and they eventually come down on the support, and they eventually get discharged from the ICU and go to the wards with the lower oxygen support. But very small subset of patients, as I mentioned, the high risk patients who have multiple comorbidities as well. These subset of patients, they eventually deteriorate on these machines and they go on ventilator. But in spite of them going on ventilator, there are good number of patients who are still able to get better on this ventilator and to come out of this ventilator setup.
Today, we hear a lot about opportunistic infections like mucormycosis. And yesterday, we also saw a report about even Candida, which they were calling white fungus, but it was nothing but Candida. What is your experience about? Because we hear a lot of cases of the mucormycosis everywhere. What really is your experience in the critical care unit? Do a lot of patients come with that, and how do you really treat them, and what should families or what should people be aware of on this?
Okay, so I'll tell you about the critical patients. This is very common nowadays because of the increased use of steroids, which has to be done because to overcome COVID, we need to use steroids. And also, there has been a lot of use of monoclonal antibodies like interleukin 6 inhibitors like tocilizumab, which can bring down the further immune suppression and cause increase in infections. And we have seen a lot of patients with fungal infections, not only mucormycosis or candida, we also see aspergillus, also a quite common fungal infection. And the most common symptoms in the case of a mucormycosis will be a headache or a pain in the eye, which happens whenever the patient is at home. If he's not in the ICU, there's the symptoms to look out for. And usually when we have to refer them to a surgeon where they evaluate them further, sometimes they will get a CT scan of the face as well as the brain and look at the involvement of the mucormycosis. Sometimes it might not be very extensive involvement and can be treated with just the medications. We use antifungals like amphotericin B and posaconazole. But sometimes if the involvement is more, then there are chances that you might have to get a debridement. There are something called as rhinoorbital and rhinocerebral mucormycosis, which needs admission to the hospital and needs a debridement and probably post-operatively we need to have an ICU care as well. But still, mucormycosis, if it is not involving a greater part of the body or the brain, with adequate debridement of this fungal infection and with adequate antifungals, the outcome is quite good.
Doctor, there's also a few patients, not only COVID, but generally patients who have a longer stay in the ICU and then they go back. Is there any, what kind of rehabilitation do we offer such patients? Do they have any irreversible lung damage or fibrosis, or what are the other things that they need to be very cautious about when they do recover and go back after a prolonged stay?
Okay. So anybody who stays in the ICU for a longer time, for example, in our ICU setup, usually they would have undergone a tracheostomy and they would have been on a lot of sedation and muscle relaxants, steroids and antibiotics, and they eventually will become quite weaker. That's called a neuromyopathy. Other than that, they can also have a lot of secondary infections, and some patients will be nutritionally poor. So when they get discharged out of the ICU, we need to be, and some of them will be dependent on oxygen, minimal oxygen requirement. So here, these sort of patients will have a post-COVID sequelae, some sort of lung damage, and they require a good chest physiotherapy and also a good limb physiotherapy as well, so that whatever myopathy is there in the body, it gets better, and also the chest also gets better. They might require oxygen for quite some time, and eventually they take some time to get out of the oxygen. We need to be careful of secondary infections as well, and they should not contract any secondary infections. They should not, and nutritionally, we have to be more proactive. We need to give them good nutrition supplementation, and most importantly, psychological rehabilitation is also very important. They would have been in the ICU. Everybody, they would have seen a lot of mortalities. They would have seen a lot of patients. They're struggling. They would have seen somebody on the PPO always. So the social interaction is also less. There's a lot of mental trauma. So they need a psychological counseling in the rehabilitation part. And these are the basic aspects of rehabilitation in a post-COVID.
So in our ICU, in our hospitals, how do we ensure that the patient is able to, is isolated from the family, but is there any mechanism by which the family can motivate them? I mean, if they're, of course, in a position to talk, are we allowing that? And how does the patient get some positive motivation, or even the family feels much better when they can talk to the patient? Does that happen?
I forgot to tell about this. This is a very important aspect. I want to talk about it. So here, as you rightly said, they are actually secluded in a place in an ICU, and they're all wearing a personal protective mask and respirator, so they can't see the face. Here, what we have done in our ICU is, with the help of the mobile devices, mobile or an iPad devices, so we do a video calling to the family every day. So the patient who is not on ventilator, patient who is on a high flow machine or a non-invasive ventilation or an oxygen mask, they'll be able to interact with the family, talk to them, and that causes a lot of reassurance and motivation. Along with that, the doctors and nurses also make sure that we talk to them every day and reassure them, give them a lot of positive thoughts. And every day from the ICU, there will be a counseling to the family members of the patients. One particular doctor will call every day, twice, to the patient's family and update about the condition, whatever the prognosis is going to be further, and also make a video call to the patient as well, and they can interact. And sometimes, if there is a possibility, and if there are, we allow some mobiles and iPads, which will not be taken back unless the patient gets better, so that they can interact with the family inside the ICU.
So you were talking about PPE kits. So is it that in the critical care, what are the infection control practices that are used so that the doctors and the health personnel also stay safe and the patients also, because they might be in separate cubicles, or how do we do the infection control protocol and sanitization inside the ICU?
So we have a separate infection control team and infection control protocol as well. And so anybody who goes into the ICU, there is a strict order that everybody has to wear a PPE, and there is no exception. Even X-ray technician, a paramedical staff, or the one who delivers the food also has to wear a PPE and go into the ICU. And there is a separate donning and a doffing area wherein you don the PPE separately, you see the patient, you come out and doff it separately. And there has been a proper cubicle for each patient, so that even if the patient develops a secondary infection, in spite of COVID, there is a adequate barrier nursing for each patient. There are isolation rooms as well. Sometimes we do some remote monitoring. Like for example, we get the monitors outside and monitor them as well, so that the contact with the patient also is minimal. But as you know, there are certain procedures we need to do with the patients, like what we say when we put the patient on ventilator, or when we put something, lines in a patient, central lines and arterial lines. We need to be in touch with the patient, so that we have to be very careful. So we use adequate hand sanitizing techniques. We use gloves, and we also take precautions so that the aerosol generating procedures will not be affecting the healthcare professionals. And an N95 mask and the shield is a must for all the doctors. And most of the doctors use the respirators, and that's how we avoid the cross contamination of the staff. And even the duty schedule is in such a way that the doctors won't, if at all a doctor gets infected by any chance, they will not infect the others, so that there will be rotation of the duty shifts. And usually the gap, once they come out of the ICU as well, they won't get together in the groups or have their food together. There will be always proper social distancing and proper hand sanitizing techniques and mask wearing. So these are the techniques we use in our ICU to provide the cross.
What happens if a patient who is critically ill and not a COVID patient? What if those kind of patients contract COVID-19? Is it how vulnerable are they, and how severe will the disease be in such a patient?
So critically ill COVID-19 patients will be quite sick in the ICU, and they usually require a mechanical ventilator. And most of these patients will go into something called as a cytokine storm. That means a lot of interleukins or inflammatory mediators get released in the body, and they go into multi-organ failure, something called as you can develop a renal failure, you can develop a liver failure, your circulatory system can can have what we call as hypotension and shock, and sometimes it also develops some secondary infections which can cause septic and septic shock. So these sort of patients, they tend to be very ill, and the mortality is quite higher in these patients. But with adequate antibiotics and with adequate mechanical ventilator support and ICU measures, there are few patients who have come out of this kind of critical illness as well.
Doctor, there are some few questions from our live, from the FB Live page as well. One is that what is the best way to manage a COVID-19 infected person if there is no immediate medical help available?
Okay, so this question is very suitable for somebody who is at home, and somebody whose oxygen saturations have fallen below 92%. These sort of patients are the ones who require the medical help. So the ideal thing to do is consult a medical person and also the medical helpline. In case it is difficult and you know the overwhelming cases, the best thing is to have an online consultation with the doctor and start the medications at home itself. And sometimes there are some oxygen concentrators which are available in the market, and that can be acquired, and the oxygen can be started at home, though it is not advisable because these patients can deteriorate very rapidly. but there is no other way to get out of it. So probably start the treatment at home, and as soon as the bed is available or allotted in any of the hospitals, better to move them as early as possible. But still, these things can buy you some time, the oxygen support and some medications. They can buy you some time so that you can tide over the crisis and you can have some better treatment before you leave the hospital.
The last question is again about the white fungus and black fungus. So they're asking about the white fungus.
Okay. So Candida infection is not new. Actually, it has been there for quite some time, and we see quite commonly in an ICU setup. And it involves various parts of the body. And there are a lot of medications for this anti-white fungus or Candida infections. We usually use antifungals, and usually this will not be so infective unless you have some immunosuppressive, like means your immunity is very low, and because of the use of steroids or immunomodulators, as said in COVID-19, and certain subset of patients, like patients who are in cancer chemotherapy, a patient who are having the patients who are elderly, the patients who are diabetic, and the patients who are using some immunosuppressive medications, steroids for a longer time. These sort of patients, they tend to get very ill with these fungal infections, and it has to be treated with a higher antifungals, and it has to be done in the intensive care setup. But as such, if it is a smaller infection, and if it is just involving the mouth or if it's just involving the skin, it can be just treated with oral medications given at home. So no need to panic about this white fungus, and it can be treated with adequate medical measures.
So thank you so much, Doctor, for this wonderful discussion. And it was really, I hope our viewers are reassured that the best of care is available for critically ill patients, and they can be managed, and they do come out successfully from COVID-19. As usual, you can post your comments on questions and queries on the comments section of our page. We will be meeting you again on Monday with a discussion on handling insomnia. Now, this lack of sleep is a common symptom that is affecting both COVID and non-COVID patients and families, and generally sleep-wake cycle is quite affected. So we are going to talk about this important topic, and this is going to be discussed by Dr. N. Ramakrishnan, who is the director of our critical care unit of Apollo Hospitals, but is also a sleep specialist. Meanwhile, have a good weekend, take care, be safe, and especially don't forget to SMS, which is socially distance, wear a mask, and sanitize. And when we say sanitize, it means that you need to wash your hands thoroughly for 20 seconds and methodically covering all parts of your wrist and hands. Make sure that you sanitize and stay safe and healthy till we meet again on Monday. Thank you and namaste.